Pues uno. Buenos dias. I'm sorry. Good day. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Sauhan Cekirge, I hope I'm pronouncing that correctly, from Turkey, who's been invited by Luis Lopez Ibor, the mentor behind this station. And I'll let Luis, who's going to be the host, moderator today? Are you going to be moderator today?
What is?
Okay, Luis. I'll introduce you.
I'd like to present a little bit Professor Sauhan Cekirge from Turkey. Is a neurosurgeon, but he started in United States 2003 to endovascular procedure. He is the pioneer. This professor is pioneer in the management of onyx, in AVM, also in aneurysm, but also is expert in another device. And the most important is he have many cases and very interesting case. Thank you, Professor Saru. Whatever you want, you start, okay?
Okay, so still I am on, or do you want me share again? I think share again?
Yes, please.
Okay. You see me now?
Yes.
Not complete. You make it presentation mode, big. Make it bigger. Perfect.
Okay, good. Excellent. So thank you, Luis. Thank you, France, for the kind invitation. So I will discuss in the next 40-45 minutes what we do with the complex MCA bifurcation aneurysms. Especially I like to mention about the art of simplicity concept for the solution of this complexity. So what is complex MCA bifurcation aneurysms in unruptured setting? So I will divide it in two settings, unruptured setting and ruptured setting. In unruptured setting, basically the complex aneurysms means that both trunks, or sometimes three trunks, is coming off the aneurysm sac. So they were used to be complex surgical cases. However, with the endovascular approaches advances, many techniques were developed for these aneurysms. Some of them by us, some of them somebody else. So basically for these aneurysms can be treated with double balloon remodeling and stenting or coiling, or double stent assist coiling, or flow remodeling treatment with an extracellular flow diverter placement, which I'm going to focus more. Dual balloon remodeling was the first technical solution we started to do back in early 2000s with the introduction of high-perform balloons. So Luis remembered these cases. He used to do this too. So basically, mostly in unruptured aneurysms that we were doing it at the time. And basically, you can put two balloons to reconstruct the neck of the aneurysm with safe occlusion. However, the paper we did showed also with many people, this doesn't change the durability. Since there was no stent, the durability was not significantly changed in terms of regrowth rates. Then dual support has started to be applied with Y stenting, dual stenting. So this technique obviously better neck repair, neck reconstruction. And first, Lopez and Wu et al. Suggested this technique with two open cell neuroforms. However, our team in Ankara discovered that this technique can also be applied using two stents with closed cell design immediately after Solitaire Enterprise had become available. The issue also, my wife also described the X stenting for complex ACOM aneurysms. So in the dual stent reconstruction, especially since the second stent with the two closed cell design did not fully open at the neck of the aneurysm, it creates a flow diversion point and makes a flow diversion in those cases. How we prove that? We clinically prove that. We come up with Y-stent flow diversion technique used into enterprise for the giant basilar tip and partially clotted aneurysms, which we don't want to coil, because if you coil it, the patient is not going to be good. So we just placed two enterprise in Y fashion, and at this point you have a flow diversion point in the just the crossover, and as you see 3 months later, just with Y stent flow diversion with no coiling, aneurysm got smaller, and you see that this is the pre-treatment and 6 months MR. So we come up with this technique and publish that. Then Kono and Terada in their CFT analysis paper show that actually crossing Y stents with two closed cell stent design has the same effect of flow diversion from basilar to P1 with a flow diverter, even stronger. So this was the main reason that these aneurysms with Y stent assist coiling with loose packing were staying very stable, as you see here. These are mostly very complex cases. And this was published at that time. The question was, unfortunately, in Europe, there was no prasugrel and ticagrelor that cannot be used. That's why with clopidogrel, people are having a lot of complications, and there are a lot of bad papers about this, and all because of the anti-aggregation quality was very poor, which was because of clopidogrel. Now, they also prove that this can be done with very low mortality, actually, with the second generation prasugrel and ticagrelor. Then the mini stents came along. The mini stents starting from Elvis Jr., then Baby Leo, then Atlas, then Elvis Evo. So with Elvis Evo, we can put a stent through a headway duo microcatheter, which is 1.5 French tip, which was amazing. If somebody tells me this 15 years ago, I wasn't going to believe that. But technology did this. That's why with this loop assist technique we developed in the intrasaccularly, we can place two stents to reconstruct even this giant, very complex trifurcation aneurysms that we place two loops and two Elvis Jr. to reconstruct these arteries and bifurcations. During this observation, actually, we observe the geometrical modification is very important in the bifurcation. When we used to do enterprise-assisted stenting, we immediately realizing that the geometry is changed. That's why the result was coming with no really tight packing of the aneurysms. Because geometrical change was something important in the bifurcation. Look at this angle, which was like maybe 30, 40 degrees. Now this is 90 degrees. So the angle is completely changed here. And because of this angle changed, then you have the result. And sometimes we failed. In this case, I was doing a Y stenting and placed just a single solitaire stent from inferior trunk to M1. And when I was trying to stent the superior trunk, it just didn't go. So we have to quit the procedure. However, what we realized that with just geometrical modification effects of the solitaire stent, we have a very interesting flow remodeling response. At that time, we didn't even know the name of this because we put the name, it's flow remodeling in the aneurysm treatment. And in the same time, there has been a big journey was going on for the large and giant aneurysms with the pipeline. The flow diverters was meant to be treating the flow of the especially large and giant aneurysms. There was many things was done and all failed, and maybe the vessel grafting was good, but finally the pipeline revolution came through. However, has been the real revolution of the pipeline is to the sidewall for the sidewall large giant aneurysm treatment, although they were meant to be. The answer was definitely no. The real revolution was it made the treatment possible for these aneurysms with multiple vessels coming off the sac because of its flow remodeling effect. Can you imagine? Look at this reconstruction is being made by the flow diverter stents. no clip, no coil, no nothing can do this. So basically, because of this real evolution, we create a concept that we called art of simplicity. Because, we are, actually, I'm not neurosurgeon. I'm an interventional radiologist. And we like complex things. We love complex things. However, as Master Leonardo says, simplicity is the most ultimate sophistication. This aneurysm was treated, one of my former fellow, she just left fellowship and he went to his practice and treated this patient with this simplicity. And this is the 8 years follow-up result in this particular patient. And the most important factor was that flow diversion was, if you apply the flow diverter placement across the aneurysm, which has a very important integrated vessel, anterior choroidal artery, peak pica, whatever, you have this Photoshop effect we used to call. You have a new parent artery and new on the origin of anterior choroidal artery. Because of its flow demand, there was a very intelligent behavior was developing, and this was our observation. But in some cases, the results have been somewhat different than what we used to see after intrasaccular treatment. Because there is as you see, we used to call this as an aneurysm remnant. Actually, this is not aneurysm remnant. This is a reverse progressive remodeling of the aneurysm sac. The embryonic posterior communicating artery is becoming a continuation. Okay, so basically, this was the concept we've been developing, and we were also learning. I tried to work on the flow mechanics a little bit, and flow diversion is a very complex biomechanical equation, providing a very complex flow remodeling cascade of the parent artery across an aneurysm neck and aneurysm sac. And this is not MCA, this is a basilar tip aneurysm with a left PCA and left SCA coming off the aneurysm sac. Very simple treatment, a pipeline from basilar to P1, change the geometry, go to the easy trunk, and look what happened. While the aneurysm is closed and remodeled, the aneurysm sac become actually with two separate channel continuation of the left P1 and left SCA. So this is an amazing morphological, anatomical, and structural change you see that we never achieve such a result with no clipping, with no balloon assisted coiling or with stent assisted coiling. Very simple treatment and such a flow remodeling response. And with this simplicity, we've been observing very interesting reverse remodeling changes, where the anatomy and is changing, especially involving important vessels. And look at this. This is anterior choroidal artery is coming off this aneurysm, and this is the fenestration in this mid basilar, and one of the arm of the fenestration was took and a pipeline placed, and there's another pipeline placed here, and look what happened. And there is a new origin of anterior choroidal artery, and there is a new, completely new basilar artery. This was a morphological, anatomomorphological changes happening. And the new origin is becoming from the reverse remodeling of the aneurysm sac. So this equation, actually, we all think that the mesh density is the most important factor for the flow diversion. It is not. The most important factor is a geometrical modification and wall pulsatility change that Luis used to say years ago. And there's a patient-specific biology also and flow demand of the integrating vessel. So with that most important factors, when you have such a sick vessel, you see that this plastic sick vessel, which I used to follow this patient, then she came with the bleeding, you bypass the neck and you change the geometry and you have an endovascular bypass. So basically, this was something else happening here. We've been trying to understand. And the flow demand of that integrated vessel is also important. But when you have such an anterior choroidal artery aneurysm, that you see clearly the anterior choroidal artery is coming off the aneurysm sac, right? Clearly. So you place a flow diverter stent, which is pipeline, and 1 year later, look what happened. This was previous origin of anterior choroidal artery. Now there is a new origin of anterior choroidal artery, which was amazing to see. That new origin of anterior choroidal artery is being formed. Basically, the proximal anterior choroidal attached to the ICA was being formed by the reverse remodeling of the aneurysm sac. Very intelligent. So this shift, paradigm shift, created by flow remodeling concept inspired us to treat complex MC aneurysms. We start to look at them in a different angle. You know, looking like this or this. So this was, again, embryonic PCOM, right? How about if you look this MC aneurysm like this? So it's the same thing. So you basically place your flow diverter here. So initial cases, and this was the first case that I placed a pipeline, and when I present this in Val d'Isère, they were almost killing me there. And this was something new at the 2008. However, I was really believing that. And this was, the main question was, doctor, you're placing a pipeline stent across the aneurysm neck. How are you sure that this aneurysm is going to close? Was this result reproducible? Yes. Now I can clearly say after 15 years of later, it is reproducible. But we need to change our look angle of look to the aneurysm occlusion. That's another thing also. So, and inferior trunk is coming off the sac. And again, yes, this has been reproducible. And again, very critical vessel is just coming off that aneurysm. I mean, you can manage that. You can put a balloon and protect it, and surgical clipping is an option here. But just look at the simplicity that's being done here, and look at the intelligent behavior of the treatment. Aneurysm is gone, but the integrated vessel is patent. So, is placing a flow diverter in complex MC aneurysms that can be treated with conventional stent-assisted, dual stent-assisted treatment is acceptable. Can just placing a flow diverter, an easier trunk, is a good option? I'm clearly saying yes. I was the one who was doing a lot of Y stenting, and we did many, many papers, and it's a still very good treatment. However, look, very two similar aneurysm. Left MCA, superior trunk is coming off, and the Y stent assisted coiled, okay, good result. And another left MCA, superior trunk is more worse angle, and just simple pipeline placement and 1 year control. So what happened to that superior trunk? It is, we call it class 1B occlusion. It got thinner because of the flow demand. This patient is not symptomatic. So this treatment also made us to treat even more complex aneurysms. I mean, look at these aneurysms. Do we treat those on geometry with stent assist coiling? Most of them, no. This was a case we did in WLNC in some years ago in our life case course with a lot of discussion. Then I just had my younger fellow put a simple pipeline at the neck of the aneurysm to the easy trunk. This is immediately after, and this is 1 month CTA, nice remodeling. But because of the flow conduit needs to be continuous, there is some remnant here. We used to call those aneurysm remnant. But after consecutive angiographies, we come up with new classification, and we're not telling these as an aneurysm remnant. We're not saying that these are not aneurysm remnant because they are staying stable. That I will show you many, many examples. Again, this is a new era which we call it indirect flow diversion. So we were able to treat the aneurysms from a secondary parent artery, not the primary parent artery, with a remote flow remodeling. So this treatment has really dramatically changed the aneurysm treatment. So it is just change and modify the flow from a remote flow diversion. And it's actually with Jan Fihler, we described that in a different paper. And there are ways of doing in flow diversion. This is how we do the indirect flow diversion. There is a parent artery, but you're treating the aneurysm from a secondary parent artery. And this is a very nice example. Look at this complex bifurcation. The disease continues from the superior trunk. And I got this case from Jivan, me and Luis's good friend from Istanbul. And he did a very simple treatment and placing a inferior trunk to M1 pipeline. And you see, 1 year later, not only the main aneurysm is gone, but the secondary aneurysm on the superior trunk is also flow remodeled and closed with indirect flow diversion effect. So the treatment concept and target needs to be understood. First thing, we call it simplify, geometrically modify, and let it flow remodel by the time. So this is a complex aneurysm. Superior trunk is the easy trunk. Simplify, geometrically modify, and let it remodel. So remodel 6 months and 2 years and 5 years. And basically you go to do non-dependent, straight, easier trunk if there is one tougher trunk, as in this case. You go there, you place your pipeline, and this is a class 1A occlusion. And 3 years later. And in such complex bifurcation, the problem is not every flow diverter gives you the same result. Excuse me. It has to be chrome cobalt, strong, with a strong CRF, with a chronic geometrical modification effect. Look at the two sequential aneurysm, and look at the angle between M1 and inferior trunk. Immediately after pipeline placed, the angle changed to from 90 to 150 degree, and 7 months later is 180 degree with a beautiful total occlusion of the aneurysms. So basically, this chronic geometrical modification is the most important factor of the flow diversion. And there are many, many examples like here, a wide neck blister-like superior trunk MCA bifurcation aneurysm. Again, with the geometrical modification, chronic geometrical modification, not only the aneurysm in bifurcation, but also the aneurysm on the superior trunk is remodeled. Many examples, you see, multisegmental disease, angle is tough. However, this is immediately after. And look after 10 months, how straighter now. That's how you got this occlusion. And many, many examples. I used to treat all these with very complex maneuvers. Sometimes I was sending these patients to surgery, especially in unruptured setting, but not anymore. And this is the 5 years control in this particular patient. If both trunks are relatively easy, this means that actually you can treat this aneurysm with anything, with the balloon remodeling, with stent-assisted coiling. However, me and Işıl, the more we see the results of pipeline is so good, the less we do stenting, stent-assisted coiling, because the result is so good. And look, the flow diverter placed, and look 1 year later how the angle is changed, And actually, this is a class 1C occlusion. This superior trunk is not filling antegrately. It is so fast that you can only understand with 6 frames per second angiography. But this is class 1C occlusion. And this is the 1-year control. And another wide neck. Look at this angle. Angle is being changed. And in the chronicle, changes being developed. And this is the 1-year follow-up, completing the job. The integrated superior trunk is thinner now, not occluded, but thinner, which is a class 1B occlusion. Another one, as you see, you're not doing this with all MCAs, but really tough ones for endovascularly. And look at the post-treatment and 1-year follow-up, the appearance. It is completely straight vessel now because of its strong CRF. And it was shown that actually pipeline flex shield has much better geometrical modification effect than many, even 64 wires, new flow diverters like Evolve or Pipeline Vantage from the same company, or Silk Vista Baby, all kind of things. So basically, to be able to get these results, to see this result, you have to be selecting the flow diverter. And if both trunks are difficult and dependent, choose the larger trunk. And in this particular case, the both trunk is difficult with a reverse angle. So you make a loop and take the larger one, which is inferior trunk here, and let the superior trunk and aneurysm remodel by the time. And this is 6 months. And you see the before and after, there's still a good angle change. Small profile flow diverters do not change geometrical modification, do not do geometrical changes. That's why Silk Vista Baby-like flow diverters do not work in MCA bifurcation or ACAM. However, it works here. This is a distal MCA aneurysm. Actually, this is a post-central sulcus artery. This is the aneurysm, and central sulcus artery is coming off the aneurysm sac. Nightmare case. Okay, we used to do a bypass here for the central sulcus artery. Then the Silk Vista Baby was just placed across the aneurysm, jailing the aneurysm and the central sulcus artery. And look what happened at 6 months. Aneurysm is down, but central sulcus artery is perfectly filling. Again, this is the central sulcus artery before and after. And however, if you look at the angle of the post-central sulcus artery, is not changed a lot. So in the distal, angle change is not that important. So modern antiaggregation needs to be adapted if you want to do this treatment, okay? And you have to use Prosugrel and Ticagrel. And if you do treat such an aneurysm, easy to treat with other means. And if you still have to use clopidogrel, I've been always saying people that don't do it. Don't place a pipeline across the MCA bifurcation with clopidogrel, even when you test it, because this is not reliable drug. It has a fluctuation sinusoidal effect on the receptor. That's why when you test them, you got confused. You have a different result in the morning and the evening. So basically, don't do this treatment if you have to use clopidogrel. So this is our protocol. Our main drug is Prosugrel. We haven't been done single aneurysm with other means, not only flow diverters, since 15 years with clopidogrel. Prosugrel is our #1 drug. But if the patient is older than 70 and there is a recent surgery, and if there is a ischemic brain, we can use the ticagrelor too. And basically, these are our loading doses. And if the patient is skinny, we can even go down to 20 milligram. As you know, the cardiologic loading dose standard is 60 milligram for Prosugrel, which is too high. We apply standardly in 30 milligram, then 10 milligrams per day. And this is the ticagrelor, same thing. And the ticagrelor, please be aware of the drug interactions. Most important one is dexamethasone. Let's say you have a giant aneurysm and you're going to place a flow diverter and you put the patient on dexamethasone during the treatment. You are in trouble because on dexamethasone can make the effect of ticagrelor zero. Post-treatment follow-up morphologic expectations needs to be adapted. As I said, when you treat such aneurysm and when you have this aneurysm appearance, I would say, keep seeing by us, we should not call these as an aneurysm remnant anymore after 2 consecutive angiography showing the same result. We call it stable flow remodeling. So that's why we have to come up with a new aneurysm occlusion scale, because the Raymond-Roy scale is not helping us, obviously. And it's not helping us because, you know, it is designed for intrasaccular occlusion. That's why we have to come up with our Cekirge occlusion. We divided complete occlusion to 1A, 1B, 1C. 1A is the complete occlusion with full patency of integrated branch. 1B, complete occlusion with the branch reduced in caliber. And 1C, complete occlusion with no integrate filling of the branch, which is in asymptomatic patients, obviously. Class 2, 3 is same. And class 4 is for just post-op. The most important one is class 5, which is a stable flow remodeling. So, class 1A occlusion, 2 examples. And basically, this is a class 1C occlusion. The superior trunk is coming off the aneurysm, sac, giant aneurysm, presented with ischemia. The patient was put on ticagrelor since there was an ischemia. And you see that very simple treatment for this giant aneurysm that we can, hustle hours to bypass this neck to do Y-stent assisted coiling, or a surgeon can hustle hours of, to reconstruct this giant aneurysm with a surgical clipping. And however, one of my former fellow again did just the placement flow diverter pipeline, and this is the art of simplicity. And this is the 3rd month later. It's a class 1C asymptomatic occlusion of the superior trunk, which used to be coming off the aneurysm sac, now is retrograde lifting. And this is the 3rd month control MR in this patient. Now look at this aneurysm. We treated this in Rio de Janeiro WLNC. M1 aneurysm, and proximal M1, there's a fenestration in the inferior arm, another aneurysm, and MCA bifurcation, another aneurysm. So in the live case show, I just opened this to discussion. There was many ideas, and some of them just told me that, Professor Cekirge, how about if, as I learned from you, take a long pipeline and bypass the whole segment and put a stent here? That's what they did. And actually, Jivan and Işıl was doing the case. They decided to coil that inferior fenestration arm aneurysm. However, this was not even needed. They placed a long pipeline, you see, and you're going to see the result now. This is the video coming. You see that whole segment is completely changed. And the inferior arm of the fenestration is closed, and the superior trunk, which used to be coming off the aneurysm sac, now it's retrogradely filling. As you see, it's very fastly retrogradely filling. Again, this is a class 1C occlusion. Pipeline is an ongoing effect, but this may bring different results. So when you see this in the first 6 months, don't call it remnant. There are many papers that people did this stupidly, and they call this treatment as a treatment failure. This is not treatment failure. What is treatment failure? Beautiful treatment is this, right? You place a flow diverter, aneurysm is gone, and the vessel is completely intact. However, if the integrated vessel was in smaller caliber, Or if there is a residual aneurysm looking appearance that stays stable, are there still treatment failure? So look at this multi-segmental pipeline 6 months later. In a 6 months result, in our classification, we still call this as a type 2 occlusion. But we never call this as failure, because even it stays stable like this is a treatment failure. This is the question. In this particular patient, it did not stay same, and it's progressively occluded, as you see here, with a beautiful reconstruction. And this is the 1-year control after such a treatment. This aneurysm reformed, restructured, remodeled to become the continuation of this inferior trunk, and after 7 years, it is still same. Another one, inferior trunk was placed, the pipeline was placed to the inferior trunk 6 months later. So don't call this as a failure immediately and write a paper. This is 4 years later, class 5 stable flow remodeling. Are we treating the picture or are we treating the patient? Before treatment, 6 months follow-up. Sometimes the time that we used to see 6 months is not enough for remodeling. Okay? We're not dealing with cosmetic surgery. Just wait. Just lower down the antaggregation or stop the antaggregation and use the aspirin. And this is the art of simplicity of the 22nd month control, which is beautiful. Another indirect flow diversion example. Intact superior trunk, aneurysm, then it continues. 6 months later, is this failure? Okay, it is not. We still call it class 2. It's not aneurysm occluded. However, we don't call it failure. We look for more. This is 4 years later. Class 1C occlusion. Aneurysm is gone, and the superior trunk asymptomatically is gone. And none of these patients, in our early experience, we had acute occlusions because of clopidograph stupidity. But now, in the long-term occlusions, with the small occlusions, we never have a symptomatic patients. This is the other one. 6 months later, aneurysm seems same. 2.5 years later, aneurysm seems same. And this is the 8 years follow-up. So this treatment is a new understanding. Is all about treating the patient to protect from a bleeding, but not treating the picture. Look at this MCA bifurcation with a trifurcation. How are you going to clip this? Not easy, right? So 1 year follow-up and 3 years follow-up. This is the class 5 stable flow remodeling. Another one, inferior trunk is coming off the sac. 15 months later, aneurysm shows such a progressive reverse remodeling, it becomes continuation of the inferior trunk and another 50-year follow-up. So, of course, there are as every treatment, there are failures, real failures. For example, this is not MCA bifurcation, but this is the SCA aneurysm treated with stent-assisted coiling, and then it just didn't close, and we put a pipeline. 1 year later, again, it didn't close, and we put the second one. Okay? Basically, the concept of flow diversion never fails. The problem is we fail because we do not know how to predict how many flow diverters are needed to have starting this reverse flow remodeling effect. This is another very complex MCA bifurcation. Pipeline vantage was shown. This was a weak structure. It collapsed. And we put the real second one. The second one is the regular pipeline. And we have this nice 2 years stable flow remodeling. Okay? And this is all right. And also, when we do the follow-up, we should not be doing only 2D DSA. Look at this aneurysm. very simple treatment with the inferior trunk is coming off, and 6 months follow-up. Oh, this is aneurysm remnant, right? And look, okay, and how about this? Just turn around, turn the other side. See, the aneurysm is reversely remodeled and become continuation of the inferior trunk. Okay, so this wasn't a remnant. The publications, as Reynaldo showed, regarding this MCA bifurcation is very, very controversial because we are, as a neurointerventional community, we were perfectly ignorant about anti-aggregation, about stenting, about, okay? I mean, a lot of, especially European INRs, didn't know what the stent is. My peripheral background is coming from the peripheral interventional radiology. That's why I was always a believer of this testing of the anti-aggregation because and also I knew that the clopidogrel was not the right drug. So there was positive articles, there was negative articles. However, even the negative articles, owners now, they changed their mind. And in Europe, especially in Moret's team, they restarted to place pipeline again in front of MCA bifurcations because they start to use ticagrelor. And they don't have those 21% permanent neurological morbidity, which they used to have it with clopidogrel. Actually, with Charbel, we proved that as a two-team, Ankara and Limoges, we proved that this treatment can be done with very low morbid mortality. Out of very complex 63 aneurysms, we have no mortality and we have 3.4% permanent neurological deficit. So this is being also proved in the anterior communicating aneurysms with the WLNC team. And this ignorance has been kept going with numerous meta-analyses also. They put apples and oranges. They never look the role of anti-aggregation, and they come up with the results that the flow diverters and the bifurcation aneurysms has a modest efficacy and relatively unfavorable safety profile. However, we also should not forget that not all flow diverters could bring the same remodeling results in bifurcation aneurysms. There were many, many flow diverters in those papers with many anti-aggregation protocols. And they looked at aneurysm occlusion with Raymond-Roy scale, which is not possible to look. And although they mixed the apples and oranges, they also realize that actually the later occlusion of aneurysms is a big advantage in those aneurysms, and they contradict themselves in this meta-analysis. So this is a new understanding, which is called art of simplicity. This is all about treating the patient. And I'm just gonna do another, I just got 5 minutes, and I'm gonna continue with the complex MC aneurysms in ruptured setting. In the rupture setting now, we have double balloon remodeling, flow remodeling treatment with intrasaccular flow disruptor, which is a big revolution here. And devices placed intrasaccular at the neck of the aneurysm, like contour device or seal device, which we have no experience at all. This is a very recent case, which I did double balloon remodeling in a ruptured case. However, it can be done with the single balloon remodeling. Also in the rupture, we definitely go for balloon remodeling. There is no question. However, if you look at these aneurysms, because of web devices and superior engineering capability and practicality and simplicity, we actually started to treat ruptured aneurysms with the web device. And this was the first generation of web that we let us understand actually the web device is a different treatment option intrasaccularly, because you got these flow remodeling results intrasaccularly. Okay, so this remnant with coiling will definitely regrow, right? However, this has a different behavior, especially with the improved technology. Now with 17 catheters, we can do awkwardly angled aneurysms, and it makes solve very complex ruptured aneurysms with a simple approach. This is a distal anterior cerebral ruptured. You go there, you place your flow diverter, you save the day, you save the patient from a bleeding. 6 weeks later, of course, there's something there, and you place your flow diverter across the aneurysm, and you have the final cure. So this doesn't hinder the future treatment. Look at this. Ruptured 45-year-old female, complex ruptured bifurcation aneurysms. Before web device, even myself, Cekirge, was sending this patient to the surgery. Okay. However, now groin to groin, 25 minutes of treatment with 6 minutes of fluoroscopy. And this is the immediate post-op. And this is the 9 months. So because of this device's superiority, it brought us the small materials, small 17 system profiled small devices. We start to be more comfortable treating all these ruptured aneurysms. And these very well monitored GCP studies of the Europe with core lab and everything showed an amazing safety of this device, not only in unruptured, but also in unruptured patients. So we also start to understand that this device doesn't behave as coils intrasaccularly. Again, when you have a neck remnant, it may stay stable. And actually, if you look at the total occlusion, it is rare. It is, in our experience, it's less than 50% real total occlusion. However, what we see always, like in this ruptured aneurysm, you have some, we call web recess remnant. And this, as you see, this is 3 years later, immediately stable. And look at this. Again, another ruptured web device, 6 months follow-up and 2 years follow-up. This is what we see in the follow-ups. Sometimes you can see some exaggerated examples, like, 3 months, 20 months, and 8 years. So what is this? Is this a still aneurysm remnant or part of the healing process? We still discuss this was a ruptured aneurysm, and I've been treating these patients for a while. I've been following these patients for a while. So it just creates a new occlusion. So to coming the end, of course, again, when there is a recanalization, there's always a treatment option. This was a regraft after a ruptured aneurysm treatment with web device. You can place your pipeline and you can complete the treatment. This doesn't hinder the necessary treatment, and the device doesn't hinder the use of other techniques combination in the same setting or future treatment. This is a complex trifurcation. You predict that the device is going to hinder the flow, and you don't detach, and you bypass a catheter bouncing your wire to the web device, and you do stent-assisted web device treatment. So you can tailor these treatments in these particular cases. So you can come up with pre-established strategy. You wire this inferior trunk that you predict a web device is going to hinder the flow. Then you place a stent after the treatment, and this is the 6 months follow-up after the baby Leo and web device treatment. I have no idea about this. This is a picture I got from my friend. The contour device, these bifurcation devices has never been available in our country, so I have no experience, but people are using those as intrasaccular devices. And very rarely we treat ruptured aneurysm with flow diverters, as in this blister-like MCA bifurcation. Okay, so this is something that we don't intend to do, but sometimes we have to. Last slide. We have different options. You can wire, you can do Y-stent in a very similar aneurysm. You can do intrasaccular flow modification, and you can do extrasaccular flow diversion. And I think now in 2025, we have to tailor this. Depends on the patient need. But the real revolution is the flow diversion. Thank you very much.
Thank you very much, Saru.
Thank you.
I think I present a few cases and the discussion is after, okay, Saru?
Okay, sure.
Okay. I think you need to close your presentation, Saru.
Yeah, I will. Okay. All right. Okay, I got
Okay.
it.
I try my presentation is this. It's okay?
Yeah.
Eh?
Yeah, Professor.
Okay,
¿Está?
necesita regular, Luis.
Yes.
Póngalo. We need to share the screen.
I show your presentation, sir.
Ya sale, ¿no?
No, you
Yes.
got to share the screen. You're not sharing the screen. No,
Yes.
no.
Ahora.
Sí, yeah, perfecto.
Yes.
Okay. Thank you, Saru, John, and Reynaldo, every participant. I like to present some case because the talk of Sauhan is real fantastic. The case is very difficult case, and he present some technique and some device to treat this complex aneurysm, but no every time is easy. Sometimes you are the complication, and the most important is, in my opinion, to treat the patient with the most sample device. I treated 20 years ago the aneurysm with fibered coils, helix fibered coils. For a company is Dendron. Also, Boston have this. And these fiber coils, the only difference is the nylon. The fiber, you are the coil and the nylon. When you have a study, stop pathological study, you are a clot with plaqueted clot. It's not easy to recanalize. I think it's very good material. I don't understand why this material stop. Henkens have a very big series. I don't know now. See, I have this material. This is the example. And Male 49-year-old, only 2 coils, 1 tetrix with basket and 1 fiber 2 millimeters. And this is the control, totally occluded, stable. Other solution is assisted balloon remodeling. He talked very well, Sauhan. This is one example. Middle cerebral artery. I put the balloon in the inferior branch. Why? You have the possibility to put the balloon here. The most difficult place here, the balloon, because the balloon have an angle and explain a little bit here is perfect to deploy the coils. Look the balloon in the inferior branch, the neck, and the control. Sometimes this patient comes with emergency, with headaches, no sign of bleeding, middle cellular artery aneurysm, and this aneurysm, this is lateral view, AP view, the have short MCA, similar to accessory MCA. It's not accessory, but the problem is you are the branch in the wall of the aneurysm. This is the difficulty. I decide to treat with double balloon remodeling. First of all, I place the balloon in the superior branch. Then I retrieve small the guide wire to have the good position on the balloon, the distal branch. I put some coils, but the problem is here, you are another branch. I put a second balloon in the inferior branch. You have superior branch, inferior branch. The balloon is here, and the second balloon is here. This is the 3D reconstruction. When you inject the coils, the problem is when you deflate the balloon, the coil prolapse in the parent vessel. This is the reason I decide to change the strategy and place one neuroform or open cell stem in the superior branch, a second, this is another view, just a minute. Finally, I deploy two stems, one in the superior branch and the second in the inferior branch. And then back in and close the aneurysm. In this control, this branch disappears, but it's not important because it's external. I decide to angioplasty in the intrastem because you need every time a little angioplasty in both sides. And this is the final control. Asymptomatic. I present one case of peri-procedure rupture and endovascular rescue. Intraoperative rupture, the mortality is very low, but the morbidity is very high, normal. When you are ruptured aneurysm, quickly you inflate the balloon. This is the reason every aneurysm I treated with assisted balloon. It's not necessary, I don't use, but I have the balloon close to the neck. When it's rupture, decrease the blood pressure, pack the aneurysm, protamine, anticoagulate, and ventricular drainage also. This is one example. Coiling, rupture, more coiling, packing, stop the bleeding. Another case, this patient don't have history of bleeding. 38-year-old woman, 3 millimeters aneurysm. It's a small aneurysm used in the bifurcation. It's here. This is small aneurysm. Start the procedure by my fellow on 1022. Coil is placed 1048, but it's too big. And the coil going to distal branch. I decide to remove this coil. When remove the coil, the catheter advance and rupture the aneurysm. Just a minute. My colleague inflate very quickly the balloon, and because I'm too much inflated, rupture the middle cerebral artery. And then hypotension, I inflate a balloon in MCA, continue to bleed with balloon inflated. I think this point to this point is rupture with the MCA. I inflate the balloon just in origin of the MCA. Look the jet. This is MCA. You have a spasm. And then I decide to reconstruct no, sorry, it's not here. Just a minute. This is the rupture. Okay, I decide to reconstruct the vessel with some stent. And finally, I decide to sacrifice the middle cerebral artery. This is the CT scanner. Balloon is disinflate, and then return to bleed. At this point, I decided to reconstruct the artery. Reconstruction. This is the stem, the superior branch, but continue to bleed. Half an hour later, you are more bleed, thrombosis of the stem. I decide to close the artery with coil. Collateral circulation is very poor. This is the massive hemorrhagia. One year later, 2 years later, the infection have left arm hemiplegia, left paresia, walk with help. Fusiform ACM aneurysm with flow diverter. This is a real serpentiform or fusiform. I decide to place a baby silk. Every time when I use the flow diverter, I use 2 gate wire, one to the flow and the second to protect if I have one problem. This is before the aneurysm. This is after. Before, after, totally closed. Totally closed. Also, when you have the big aneurysm, I prefer to start to use the test occlusion with balloon or coil. Look, this aneurysm, giant aneurysm. I'm going to the hospital to treat them and spontaneous thrombosis of this. Spontaneous thrombosis. Very lucky. Don't treat. Another fusiform, serpentiform aneurysm, initial, distal. This is MR. I decided to treat with coiling because have a very good collateral circulation. Totally cure this patient. And finally, is rupture aneurysm after web implant. And this is the reason because I don't like to use this material. 61-year-old, asymptomatic. I decide to use with the Proctor web device. This is the aneurysm. In the superior branch, you have 2 branches. This is the aneurysm. This is to decide the length of the web. More projection. When the catheter, guide catheter, look, is here. The web come here. This is the guide wire. The web going just in initial part of the neck and massive rupture. at this moment, with my colleague, compression of carotid, I decide to implant one stent. This is the web in the neck. This is the stent. Stop bleeding. You are here. The stent, the web. CT scanner. You are some part. This is the web, the vessel, but it's open. The stent, the web inside. Finally, result is this. Some part of the aneurysm is still open. But 5 years later, 2 years later, still open, but no increase the size. And finally, MR totally closed. This patient is asymptomatic. After this procedure, total asymptomatic. Okay, thank you. This is some example to discuss with Sauhan. Okay.
Thank you, Professor. Can I do any question?
Sure.
It's a philosophical question. The MCA in aneurysms usually has a complex shapes, such wide neck incorporate the proximal part of M2, thereby rendering them usable for endovascular treatment. Furthermore, a surgical approach for MCI aneurysms is straightforward, and previously studies have reported excellent outcome of clipping of MCI. So, what we do with to combat with the neurosurgical treatment or endovascular treatment is a question open for all the audience and for the professor. Sario, what do you think about that?
Well, if you ask my opinion, in 2025, this is not even a valid question. Sorry, my friend. In the vascular treatment, I just saw that Luis's case. It was not a proper case for a web treatment. I think the wrong proctor, wrong education, and with that angle, he should not be trying this aneurysm with web device. So basically, the patient selection is important for the technique. But now we have many, as I show in my last slide, we have many options. We can do wide stent, we can do intrasaccular, we can do flow diverter, especially the art of simplicity approach with flow diverter is so simple and safe for everybody. So although neurosurgeons always talks about, it's easy surgery. There is no easy surgery. If you ask this to the patient, okay? If you are patient, there is no easy surgery. Your head is opened. So basically, this is something that we've been discussing for years and years. That's why, but we come to the conclusion that many neurosurgeons, after they are 50 years old, they quit doing surgical clipping and they decided to learn endovascular. Look, Chris Ogilvy, okay? I used to fight with him a lot. I used to have a big fights with this guy, okay? Now he turned out to be endovascular guy because, it's the reality. It's simplicity. The Reynaldo, I'm a guy, I like to do complex things with as Luis, okay? But you see the simplicity. Now with this simplicity, everybody can do this. That's the real art of the beauty, okay?
Professor Luis?
Yes. I agree with Sauhan. The flow diverter is the fantastic material, fantastic device.
But not every flow diverter, Luis. Not every flow diverter.
Not every.
Not
Not
every.
every.
Yeah.
Of course. I like silk. I like papeline. I don't like another. But for me, it's not the discussion, the indication of flow diverter or not. See, you have the possibility to treat flow diverter, and you are in your suite, you treat it with flow diverter. This is okay. But intrasaccular flow diverter, Luna, Web, another. The problem for me is you close this the fundus and the sac, but not the neck. And sometimes you need complete the patient with a flow diverter. And the reason, this is everybody have this. And my question is, why not to treat it at the beginning of flow diverter or coiling and flow diverter?
But please, in ruptured aneurysms, let's say
for,
there's a ruptured aneurysm. That's what I show. The importance of the web device is ruptured aneurysms. Okay.
Now, listen me. For me, the rupture or not rupture is not the problem to use the web or not use one other product. Is this question, for in my opinion, is not real. The question is, the patient have one aneurysm and you treated aneurysm, rupture or rupture with the best device and the best way. I think it's best to pull, if you want, some coils and flow diverter or remodeling, whatever you want. Just alba remodeling, and then you, whatever you want. The intrasaccular device, the problem is the end of the web of the system. And you are indesirable movement. This is only my question. This is the reason, but I don't like. One question for you, Saru. How many no recanalization, rest of the neck after web? How you have control 1, 2, 3, 5 years? See, not change the morphology. I agree with you. The treatment is okay, but since change, you treat.
Yeah.
You treat
I answer you. So as I said in the slides, the total occlusion rate is very low with this device. In the FDA trial, it was 50%, but in our case series, a real complete occlusion. Okay, when Işıl looked at it, it is hard to call complete occlusion. So Işıl looked at all these cases, it is 28% complete occlusion. However, these recess web remnants, which is about another 52. Okay, so basically, either total occlusion or complete flow remodeling, stable flow remodeling, is 78% in our series. So there is a 22% recanalization. Okay, so the retreatment rate is about 8-9%. However, the importance is this, and most important thing in web device is right training. Okay, because the sizing is very, very important. Right sizing is very important with the web device. And the good thing also is it just saves the patient. When we used to have a wide neck aneurysm, which we can treat with double balloon remodeling or something like that. It was really hard, especially in ruptured setting, right? With the web, you can have a very simple and fast acute setting treatment. You save the patient, as you say, then you can do whatever you want later on. But you save the patient from rupture setting. The Claris study, that French study, showed that, I mean, the morbid mortality is very low with the web device in ruptured patients.
Sauhan,
Yeah.
another question. You are an expert with onyx in an aneurysm. How many middle cerebral artery you are treated with onyx?
How many?
Case or MCA aneurysm
Zero.
with onyx?
Zero.
Why?
Because it leaks out.
No. Also, I agree with you. Zero.
Because it's liquid. You lose it in the bifurcation vessels.
No. It's possible to treat sometimes, but this is I think it's very difficult technique, very long technique, and when you are the flow diverter, it's totally changed the philosophy to treatment.
Yeah, definitely. I agree.
Thank you. Reinaldo, ¿alguna pregunta por la gente?
Any question? Professor, Bob Professor, when is the best time to treat them when the aneurysms are ruptured or non-ruptured by endovascular by? I know the aneurysms is ruptured with a great hematoma is a surgical situation, but what do you think? It's better to try them when the aneurysm is ruptured or non-ruptured. I'm sorry for this question, but it's a daily for what do you think, Professor Sauhan?
I'm sorry, I didn't clearly understand. Probably you asked that what is the real indication now for surgical treatment, right?
Yes.
It's a good question. The real, if there is a real sylvian hematoma, large sylvian hematoma, and aneurysm, this is a surgical case, okay? Because usually the aneurysm has no wall, and basically it needs a proximal control, okay? And there are some cases that I just put a couple of coils and send the patient for surgical evacuation. However, when we look at the surgery, the coils were out of the aneurysm already, okay?
Yeah.
Because those aneurysms with large sylvian hematoma, they don't have wall, okay?
Yeah.
This is the only, for me, is a surgical indication. And also there are some, although it is less, we need, for example, today, I send a patient for a surgical bypass, okay?
Right.
Sometimes there is a need. There is a need. Okay.
All right. Professor.
So, for me, I don't agree with you to the surgical aneurysm with hematoma. I think, in my opinion, it's better to treat it before by coiling and then remove the hematoma and clip the aneurysm you want. Why? Because when you open the dura mater and the high pressure protect the aneurysm, and it's possible massive rebleeding. It's depend of your team and your hospital, your center. See, in my team, I have a very good neurosurgeon. I decide to the patient it's better to treat endovascular or surgery. The neurosurgeon in my life don't like open, don't like Luis treat it, Luis treat it, Luis treat it. Why? Because for the neurosurgeon is 5 hours or 3 hours, whatever you want. Maybe for you or for me, it's 1 hour. And you go into the unit care, the patient is well. This is logical.
The party. All right, thank you guys. Thank you very much. I'd like to thank you for your kind invitation, Luis.
Next
Okay.
Thank you so
time,
much.
next time, whenever you want and easy, you are in my heart. Eh?
Always.
Turkish man.
You are also.
Fantastic.
You are
Yo me voy a
also.
retirar, ¿eh?
Thank you so
Thank you
much,
very much.
Professor. Very awesome cases, and I'm very happy to hear this topic. And thank you, Dr. Ruiz.
Thank you.
Thank you, Professor John
Bye-bye.
Bennett, for
Thank you, John.
Excuse me, we have one more question, Professor, from Fitri, someone you know, Louis.
Fitri.
Yeah. Fitri asked, how do you manage if a rupture happens when you're coiling? If you postpone, how many hours or days to treat it? Or do you switch to open surgery?
¿Cómo dice?
Okay.
How many?
How do you manage if a rupture happens during coiling? And if you postpone, how many hours or days
No.
do you do it?
In angio room, in angio suite. Come the neurosurgeon and place the pressure and very quickly to the surgery when it's rupture with the coil. No wait.
all right.
Okay.
All right.
Okay, there's Fitri. Hello, Fitri. Say hello. Okay, we'll talk to her after. Thank you, gentlemen. Saruman, thank you very much for participating, Louis. And stick around. We'll talk to some people, okay?
Thank you.
Okay,
Thank you.
Thank you.
Professor.
And we'll see you in 2 weeks. 2 weeks.